Thank you, and for the record, there are two Europeans on the panel, so I think we are quite diverse. So my name is Nick Anderson, and I'm from UC Davis, and I'll quickly introduce the panel, and then we'll go off in order. So on my left, got Dr. Sam Shetar, Chief Medical Officer of Northrop Grumman, Dr. Paul Dutton, Senior Vice President of Products for Quantros. Myself will be third, Dr. Dirk Boker, CEO and founder of Machine Boker, and Dr. Alex James, CTO of AI Cure. And I think with that, Sam, we'll let you start out. We are trying to draw a bit of an arc here and see if you can figure it out.
Thank you very much. Glad to be here today. I'm the Chief Medical Officer for Northrop Grumman Health. And I'd like to start by actually introducing a colleague of mine who is here. He's the Director of Technology for our Life Sciences Program, Morgan Crafts, who's also listed on this slide. Northrop Grumman has been in the health IT space for over 25 years and providing data system support, analytics, and new technologies into the health system across the public health and primary care support space. And we'll talk more about that shortly. So as we look at the health ecosystem, we see 6 key players: providers, life sciences, public health, sponsors, payers, and care coordinators. What is changing is these are all now increasingly centering around a very key element of the system, which is the patients, the consumers, the persons. It's basically about moving the health system towards helping support the patients and consumers really as the fulcrum, as the center of that system. There are 3 emerging areas that are really starting to come to the fore. The use of IT to help support public health on the bottom right, turning from just pure public health as we know it into a more robust population health focus, including healthcare elements. On the bottom left, value-based healthcare, moving towards increasingly serving and supporting not just the payment of care, but the payment of health and the support of health and health outcomes. And then ultimately precision health, making sure that the care that is given is very much personalized, focused on the individual. So one might ask, what is the role of technology in helping support this? And the simple answer is everything. Enabling technologies are able to advance patient and population-centered care in many, many ways. We all know about big data. There are 5 V's of big data, we like to call it. And it's the volume, how much data there is, the velocity of it, how fast it's coming, the variety of it, clinical data, genomic data, public health data, environmental health data, the veracity of it. Can we trust the data that we're getting? Is it verifiable? And then ultimately, most importantly, the value of the data. Does that data actually help us move healthcare forward? Does it actually move health outcomes forward? So big data and health analytics is critical to health moving forward. EHRs, collecting the data and then moving towards ultimately advancing knowledge because of that data. Mobile, to get to where the patients are. Internet of Things, connecting multiple devices together. Cloud computing, we heard a discussion about that yesterday, how important that is in terms of liberating and freeing up data for everyone to use. Data interoperability, how do multiple systems share data with each other in a way that makes it convenient for the patient. Security and privacy, extremely important in the health space, as we all know. And then ultimately government, academic, and industry partnerships. No one entity can do this by themselves. This will necessitate going forward that government, academia, and industry all partner together, collaborate together to move health forward. So technology is really a key enabler for population health progress. So this is an interesting slide. It sort of goes, tries to describe the history of technology in health. It's obviously a challenging assignment, but does anyone remember what the largest room in a doctor's office was in the 80s and 90s?
The waiting room.
The file room, the medical record room. He was the largest room, or often the largest room in a doctor's office. How much has changed in just a short span of time? And that's something for all of us to sit back and think about. Back then, in addition to the file room being such an important part of an office, most of the care was from the provider to the patient. The patient was a passive recipient of the care. Population health was really reactive as opposed to proactive, based on limited information and certainly very little analytics. We moved forward to create a data repository system through a couple of different major electronic health record activities, such as through the Department of Defense, the National EHR adoption from CMS, As a result, we're now moving towards improved outcomes, new payment models, innovation research, towards a goal of a patient as the decision maker of health, as opposed to the receiver of health, and population health that's using data and analytics to drive towards better prediction and ultimately better direction of health care and health outcomes. And all this is happening within the time frame that we've been in the business and we've been doing this work. So moving to preventive care and proactive patient care. So Northrop has been involved in a lot of things to help move this along. CMS, Center for Medicare and Medicaid Services, moved from just a focus on reducing costs, such as fraud prevention, to, and continues to focus in that direction, but also moving towards improving outcomes while reducing costs. So how do you go from fee-for-service to pay-for-performance? How do you essentially move from paying for services rendered to now looking at the quality of care that's provided and ultimately the outcomes of the beneficiaries of the patients? And so Northrop has been involved in helping through that transition and that transformation as CMS has moved from fraud detection, cost reduction, risk sharing, to meaningful use and to physician performance. Bioinformatics is another place where data and analytics has been very critical because we've been able to help support, and many others have been able to support, NIH and other entities in the research world to help better identify genomic data as well as immunological data and disease data. Bottom left is Ebola virus information. How do you then share that data so seamlessly among scientists so they can accelerate the pace of scientific research? And then finally, population health analytics. Again, something we're all very familiar with. And again, we don't have too much time to go into any of this, but just using data to picturize foodborne outbreaks, to picturize trends in public health, and to look at insurance for underserved populations, enabling more efficient health targeting and resource utilization. So to sum up, the value of healthcare analytics is to assess and improve personal and population health. There are multiple ways in which you can do it. It starts from this very simple triad: analyzing data, building and applying models, and then ultimately creating visualizations, screenshots, dashboards, and others to help ensure that people can get to the information quickly, efficiently, and move forward to provide better health care for all. And these solutions are applicable to any disease, condition, or outcome. Finally, moving into the future, we're now going to be looking at things like cell phone information, avatars, and other things. So going from data systems and EHRs to assisting the patient, the person, to monitor, manage, and direct their own healthcare. Integrating people, technology organizations to essentially foster the AAA. Better care, lower cost, better health.
Great, thanks. So, Sam's talk, I'm going to be chatting a little bit about patient safety. So, kind of my hope is to take this down sort of one more level into sort of a specific example in the context of patient safety and how health information technology can be utilized in that context and how that could be sort of more data-driven. My sort of initial reaction when I sort of look at Sam's presentation is like, wow, in patient safety, we really need some of that, right? So my background primarily is as an interoperability and exchange expert, and also have done some work in health analytics, and then took this assignment at an organization called Quantros, where we offer both patient safety and quality solutions into the market about 6 months ago. So I run product there, but I didn't necessarily come to it as kind of a patient safety expert. So I've learned a lot about patient safety in the last sort of half a year or so. And I wanted to share a couple of those insights, because whenever you take on sort of a new assignment like that to run product for an organization, to develop new services, like your background in this case not having as much domain expertise in patient safety could have been viewed as sort of a feature or a bug from a software development standpoint. And I think in many ways in this context it's probably proven to be a little bit more of a feature. So first observation, medical errors are a problem. I'm sure some of you saw a recent study that picked up pretty wide coverage in the trade press and popular press around medical errors being the sort of third leading cause of death in the United States. Honestly, as a person who makes event reporting systems, I don't know if this statistic is actually accurate or not. It's an estimate. It might be high, it might be low. The truth is we don't really know, because one of our biggest problems in patient safety is we just don't do a good job measuring patient safety, right, today. But we do sort of absolutely know, like, it's a significant problem. Like, it is not a small number of people dying as a result of medical errors. If people, say, on airplanes were dying at this sort of a rate because of planes falling out of the sky, like, people would lose their mind, right, over that. but yet in the context of patient safety, because they're sort of isolated incidents that happen sort of all around the hinterland, right? It's not necessarily tracked as clear crisply. The other thing, though, that's sort of absolutely true is like moving the needle on patient safety is sort of very difficult. It's not an easy thing to do. And I think one of the reasons why it's not an easy thing to do is because the tooling that exists today, as a person who's actually responsible for sort of selling these products to market, I would tell you are actually inadequate, right? So this is sort of what a typical event reporting system looks like. Mine at Quantaros, others within the industry. There's a lot of focus on manually capturing safety events that have occurred, right? You know, everything from sort of the mundane to the very significant wrong site surgery kind of thing. All of those things are expected to be, and in fact, accreditation processes are in place that basically says these things that you've captured, whether they're the most important thing or the least important thing, it's something that needs to be investigated thoroughly. So you have a lot of effort going into capturing these events, safety events that occur in hospitals, and manually investigating all of them. And what you get out is sort of a form of kind of weak descriptive statistic, right? In terms of just counts. Like X number of people fell, X number of people who have received the wrong medication, the wrong treatment, all of these kinds of counts that occur. Lots of activity, but as a practical matter, the system doesn't necessarily help you kind of analytically get to how do I solve the problem, right? Or even like does my rate of problem compare to sort of others? Or within a given hospital on a particular, say, unit, one unit versus another unit, am I sort of winning or losing the safety battle in that context? Like the system today, event reporting systems that exist in industry, ours and others, just doesn't do a good job of that. Like it's possible for somebody to get there by sort of taking a human, right, and having them look at this and pulling data sources from other places. But you know, again, sort of back to the prior chart, so much of their energy and effort is sort of spent on this, you know, hamster wheel, right, of endlessly investigating sort of everything that comes. There's no sort of real control put in place to sort of help separate that which I really need to look at because it's the most significant sort of problem versus, or a novel problem that we haven't seen before, from that sort of thing that you know, see again and again. The way I would liken this is, it would be sort of like, you know, the NTSB, right, does airplane accident investigation. So you could imagine if like they also tracked like minor incidents, you know, that occurred like every time somebody hits their head while standing up too quickly on the underside of the overhead bin, right? And that was sort of tracked in the system, and we required people to manually investigate that. You know, that gets a little kind of nutty, right? So there's no reason why using analytics, we can't sort of tune the system, right? To move away from just merely descriptive, but helping you to understand why things happen, what really happened, and ultimately like what you do about that to reduce sort of the cognitive burden on individuals. So a system like that would ultimately look something like this, and it's not really all that different than some of what like Bio's presentation described in the prior session, some of what Sam described. An ability to properly measure a baseline, figuring out like which kind of cohort, which are the problems that are, you know, high frequency, high value that you really need to solve, putting in place a plan of intervention for those things and measuring that over time, and then evaluating and learning, right, from that. And the way I think this sort of fits into this panel in particular is that, you know, that really only happens if you have an EMR in place, right, through electronic data. So you can start capturing these things electronically and then providing these kinds of like more advanced sort of analytical filters to this. So investigation, right, can also be automated. The sort of analytics that you're doing can help you sort of separate the signal from the noise. And that then can ultimately drive kind of clinical interventions that are appropriate to workflow back into the system. And thus you see then in a sort of repetitive way that cycle improving over time. So this is sort of my hope, right, in the context of digitization of information, an ability to manage, measure, surveil, and then put in place, you know, even when you start thinking to the sort of the far extreme, a patient that you've identified through like predictive analytics as being at risk of a fall, you know, do you have through like an Internet of Things an ability to see that in fact, you know, the rails on the side of their bed are up or not? That kind of thing is technically possible and can be done through this kind of safety performance improvement system. Thank you.
So it leads fairly quickly into my description. So I'm the, I think not historically, but the only current academic on the panel. In my role at UC Davis as Director of Informatics Research for the UC Davis Health System, which, as I will describe, is part of a very large system. So UC Health covers 5 medical centers, 10 hospitals, almost 4 million outpatient visits a year, 3,000 emergency room, 50% more transplants, so it's very focused on specialty care, including extensive burn care, and basically 20% of all covered care. And we are very charitable, almost $500 million in charity care in 2014. But perhaps the most important part is that these are 5 medical schools, which are practicing academic health schools, to which there's a lot of new adoption, innovation in health practice and digitization. Over the last 10 years, all the UC systems are now on EHRs. I think Irvine is the last one to move from its prison system to what is probably going to be Epic. So we've passed the EHR high-tech adoption hurdle, and to some degree we've passed it fairly well. We're HIMSS level 7 in many of our systems, and we are very, very digitized, and often win awards for such things. Turns out that digitization is a necessary but not sufficient step to actually get to analytics, as some of the audience will happily speak to. So I'll talk about briefly where we are as a one single governance, independent healthcare organizations, very large populations that is a public university system and a self-covered health system. So now that we have digitized our data, we're quite proud of this locally, of course, as you might imagine. Certain people are more proud than others. But to take that data and to turn it into something else is where we are really still building the paths. And we are building the paths from the digitization back into the clinical system, kind of the long way around. So we are having to develop all the mechanisms by which we can take this data, which is almost entirely for clinical care, or for research clinical studies, and to make it in all the modes and forms available for these secondary purposes. So we have active research and active implementation going on for the identification, for ETL translation and loading, for summarization, for all sorts of other stewardship and management of the data, depending on where it arose, how it was stored, how long it's been stored, and then how and whom to which we are determined to share it with. Each of our health systems has a different backlog of historical data, then it has prospective data, of course. We've done shifts in standards from ICD 9 to 10 in just 6 months ago. And we have different methods of assuming that how we digitize care. Some of us use LOINC, some of us do not use LOINC. Some of us are more template driven, some of us are not. So the secondary use, though, is a significant, we're very enthusiastic about this. And we do have multiple networks and approaches to develop research across the UC system, particularly under the general goal of using the existence of prospective or retrospective phenotypes on patients for identifying recruitment for new clinical trials. So as a big driving use case, but what is of course evolving more rapidly on top of that is where our population analytic aspects. What can we do that is on the active patient populations? What can we do that is more real time? What can we do that informs how we choose our coverage and our other outcomes in our research? So though research in clinical trials drives a lot of how we seem to maintain this secondary use, our meeting the triple aims is what is beginning to motivate our investment in the next level of analytics. We have active research on just simply profiling data between the systems, because each system has developed its own, turns out, slightly different versions of encoding clinical workflows. And only when we were able to compare across the 5 institutions did this become clear enough that we actually were required to take steps on that. So this is the rough, just kind of a rough selection of some of the UC Davis Health, data research areas. So one of the motivations, again, is that this is a very large scale and a very diverse geographic population with rare diseases, specialty care, but it is under one large single governance. All patients of UC Health are patients of, regardless of the hospital or the institution. Really motivating focuses on quality metrics and comparative effectiveness, particularly like why and how the selection of certain medications are far more adopted at one university versus the others, and what are the best practices in transfer of care, management of care between these institutions. And even though it is still difficult to determine when patients go between one health system and another, it happens, and it is something that is really looking very closely at, where and how do you manage autonomy of patients in this large environment. So we have this capability to do geographical disease and socioeconomic research that hopefully can inform our actual overall system. And we have a very unique opportunity to look at the healthcare utilization that can be based on different rare disease conditions or other aspects. So one thing we've developed and is still going on, but I will say that it's something that we've developed and we're in the process of moving to a different model, is to have aligned, harmonized data across all the UC systems. So we have almost 14 million patients. We've aligned data ontologies across the systems. We have common approaches to this data, and we have common methods and access for evaluating the quality, the profiling, and the distribution of the data that can arise from this. This is all, at this point, de-identified data, because even though we're under the same system, we've required a lot of trust barriers to be overcome in order to allow the systems to work together. But it is agnostic to the underlying data stores, so it's something that's really tried to build a common linked environment for making those technical decisions and vendor alignments and ultimately governance decisions to actually build upon these data sets. And so I'll finish with one quick slide. One example of what we're doing on this is a thing that we're developing called EpiExplore. This is purely an epidemiology environment. We're looking at the unexpected comorbidities and healthcare utilization of patients diagnosed with autism spectrum disorder based on the geographic and socioeconomic disparities across the UC systems, and looking at where are the transitions and gaps in care that are unexpected between the different ways that patients with ASD are referred to specialty institutions like the UCs, and where they perhaps find challenges in getting access to secondary care.
Hello. I would like to take you to the other side of the battle, which is basically the patient's behavior or the person's behavior, as we heard this morning. So all the technology leads you to one side and one improvement, but ultimately you need to have the patient change his or her behavior of the person. So we have developed a personalized, what we call a personalized engagement platform, which we try to bring the person to a better place, to be more content and to be more self-responsible, if you want. If you look at the cost in healthcare, about 86% are spent on chronic diseases. And if you take a closer look, about half of it, which is the other upper part here, is spent on chronic diseases for people with high acuity, high cost situations. And the other half, the lower part here, the green part, is spent on people with medium risk or medium acuity. Those are folks which have maybe 1 to 2 hospitalizations per year. So then if you look at the savings, potential savings, the upper part, the red part, you see that about 2% of those are mitigable or avoidable, whereas in the medium risk, medium acuity segment, about 4 times or 5 times as much money can be saved. So in order to do that, you can focus on this, but the problem here is that per person, the savings are relatively small, maybe $300, $400, $500 per person. So the situation is now we need an intervention scheme which is way below the cost of a conventional call center interaction. So you need to address a large group of individuals with a very effective automated system to keep it cost effective, and you need to keep it adaptive and personalized. So what we have built for this is what we call a little village. We call it Micaville. You see here 4 buildings. The metaphor is there's a village, and each building has a certain intervention scheme for you. Starting from left to right, there's a school which is basically addressing educational issues, personal areas where people need to understand how to modify their interaction, or therapy scheme with insulin pumps or an asthma inhaler or the like. There's a cafe where you have social interactions, where you help the person's interaction with others, where you can have systems, where escalation systems with a social environment. There's a library, of course, and there's home for more reflective aspects, introspective aspects, you might call that. Meditative, this morning we did some yoga, things like that for being more content with your situation. The website itself looks like this. The key point here is that the current intervention schemes address very much the educational portion, where people are helped to understand what to do and what not to do, but as we all know, that interaction doesn't lead necessarily to behavior change. Everybody knows basically eat better, sleep more, drink less, but that doesn't do it. The other aspects of an individual's, what drives decisions, we have found that about 95% of decisions, what people do, are driven intuitively, and as long as you don't load that intuitive memory, people will not follow eventually a behavior change pattern. Discipline doesn't only take you so far, and in order to have a sustained change, which goes for years and years, you need to load the intuitive memory, and that can be done with social interaction, with emotional interaction, and you need to understand the person's environment, and all that needs to then be put together into an intervention plan, which is adaptive over time. We have built this, and if you compare this with conventional schemes, we start with a psychographic, we call it a psychographic analysis, which is basically a brief assessment of the individual's psychology traits, and that linked with emotional situation, barriers, and goals. You cannot lead a person to a situation where the person doesn't really wants to go, intuitively wants to go to, so you have to understand that. There's, compared to a current educational approach, which I said, we add all the other aspects which makes it more holistic, and the person perceives it that way. It's a low-cost intervention which is fully scalable to large memberships, and it's a system, it's an open system. We invite other third-party apps which have other different solutions, let's say a fitness app or a cooking app or other apps which is beyond even medical, which addresses a person's situation. As we all know, situational depression needs to get the person in movement, so ultimately you can then interact. And finally, the predictive modeling, our predictive modeling is based on the effectiveness of the power of the intervention rather than on cost and risk alone. We have reached pretty good results so far. We improved clinical outcomes for some of our customers by 20%. We reduced dropout rates by 15%, increased enrollment and support programs by up to 45%. And the overall loyalty of customers or persons in our programs is much higher because it addresses the whole person's individual and situational circumstances. The improved retention in population health programs, we have up to 10% improvement there. So all in all, we have developed a new approach which we understand as a holistic approach to an individual, which is low cost, which is ongoing, which is adaptive. It can add to any type of conventional population health program. We work with health plans, we work with disease management companies, we work with pharma companies who have medication programs. And the personal intervention plan is adaptive, very important. Situations change over time, so they have to change barriers. As they overcome barriers, that needs to change the plan. And finally, the discipline oriented approaches today can can be replaced by an approach which actually gets the person to a happier place and becomes a more content person, which is a prerequisite of long-term behavior change. Thank you.
This one. Hi. I'm Alex James from AI Cure. I'm new to healthcare. I moved to AI Cure about 9 months ago, and before that I was at Yahoo and at several large companies. So my background is in machine learning and AI. So what I'm going to do is first talk about AI Cure and what we do, and use that as an example of where I think things are going in terms of analytics. So what we do focuses on adherence, and this is not a new term for all of you, I would hope. And the two main areas are clinical trials and population health, specifically high-risk, high-cost conditions. And as we know, in clinical trials, the risk of non-adherence includes failed trials, ineffective unsafe medications, higher costs, delays, and so on and so forth. In population health, obviously poor health outcomes and higher costs. So it's a really important problem, and as you know, it's a part of a bigger ecosystem where when people don't take their medication, it leads to poor health outcomes, which leads to increased service utilization, higher costs, and those are passed on to the patient. So it's really a critical component of the healthcare ecosystem, and as you know, the costs are huge, and it's not just the financial costs, and you can see some numbers here. About 18% of the GDP is the cost of healthcare. In the US, clinical trials alone is about $51 billion a year, and non-adherence costs are estimated to be between $130 and $300 billion in the US only. So huge, huge numbers. And if we look at the health costs of non-adherence, again, they're really, really gigantic, up to 10% of all hospitalizations in the US. So let me ask you a question. Have you always taken your medication as prescribed? Raise your hand. I see like 2 or 3 people. Do you also brush your teeth right before you get to the dentist office? Yes. So the reality is we're really bad at it. And how bad are we? Well, in clinical trials, it's between 43 and 78%. In population health, it's about 50%. It's estimated, because the reality is nobody knows what adherence is, right? And that's a pretty amazing thing. Our mission at AI Cure is to de-risk clinical trials and improve health outcomes through artificial intelligence. And so now I'll show you a short video of how the platform works, and then I'll go back to explain why I think this kind of platform is the future of healthcare.
For millions of patients, taking medication is vital to staying healthy. Yet half of all patients do not take their medication as prescribed. At AI Cure, we use artificial intelligence on smartphones to visually confirm medication ingestion. We make sure that the right patient is taking the right medication at the right time. Biopharmaceutical companies, providers, and payers benefit from new efficiencies and higher quality data, allowing them to focus on those patients at highest risk of poor adherence or hospitalization. By leveraging intelligent technology on devices that people already have, AI Cure has developed a powerful, accurate, and scalable adherence tool. The interactive technology can be downloaded as an app onto any mobile device and is designed to adapt to patient behavior over time. The platform can be customized according to disease type, patient demographics, and risk factors. Improper use or
Go back to the slides. So it's fully automatic. It doesn't need any human review. The videos don't even have to be recorded. It's all done on the device. And what we're really aiming for is an intelligent medical assistant, which means we're working very hard on some additional aspects of that, because we understand that adherence is not just about surveillance. So this includes gamification, education, incentives. What are the opportunities? And if you look at the number of smartphones around the world, it's estimated that by 2020 it'll be about 6.1 billion. And one interesting fact, and people have talked about this with respect to the NASA program, but the phone you have now is more powerful than the one that was launched with Orion recently. There are many reasons for that. But the bottom line is that these mobile devices are extremely powerful, and the stuff that I just showed you runs on $10 phones. We're using only maybe 1% of the capabilities. So the opportunities are huge. These are some of the features of the platform, but I think they extend to any any kind of application that uses similar technology on mobile devices. So it's scalable, inexpensive, interactive, adaptive, sensitive to language and literacy levels. It allows real-time interventions, big data insights, and you have all security and regulation features, and so on and so forth. So one of the powers of this is, again, you have the ability to have one-to-many outreach interventions. So that increases the quality of care, patient satisfaction, and lowers costs. In terms of measuring behavior, so we've deployed commercially. The company's 6 years old. We've deployed a number of therapeutic areas with several companies. These are some of the areas: schizophrenia, stroke, TB, opioid dependence, Hep C, HIV. And the beauty of having this kind of platform is that you can measure behavior in a more continuous way. If you compare it to blood levels in clinical trials, you get a lot more data, which is much more reliable and much richer in terms of what you can do. This is an example of behavior in adherence behavior across 4 different patients. These are real patients, where if you look at the average, it's about the same, but the way they take their medication varies significantly. So there are many opportunities that this kind of platform can give us. And I think the key in all of this is to take a human-centered computing perspective when you're developing such technologies. So it's really working at the intersection of user experience, data analysis, what I call the human aspects, and then applying AI and machine learning right at that intersection. And a typical meeting in our office often includes people with many different backgrounds, such as the ones you see here. Ethnographer, data scientists, engineers, experience designers, public health experts. It's really, really interdisciplinary, and that's what's so fascinating about this. In terms of innovation, and echoing what some of the other speakers have said, I think it's critical to have the human in the center of the process, in understanding the data, forming the hypotheses. And in our case, and I think for any application that uses mobile phones, which I think is the future, it's understanding how people use the devices, understanding engagement, and then understanding how people in the back end, in the dashboards that are getting the data, understand that data. So it's a cycle: data, hypotheses, design. So the main points that I want to get across, and again, I'm using this as an example, but I see mobile devices and data integration as the future, but not blindly. So we're taking an approach where we're really looking at specific therapeutic areas, and the deeper we go, the more we learn about those therapeutic areas. And that includes, aggregating all kinds of data from wearable sensors, even social media. I mean, there's so much data out there already that I think that's where things will go. Adherence, I think, is a critical part of that equation of understanding patients in healthcare. It's definitely interdisciplinary. There's no artificial intelligence magic. There's so much buzz about AI today. It's insane, but the reality is different. It needs to be interdisciplinary. It needs to be really human-centered, and that means we need to consider patients, healthcare staff, businesses. In terms of EHR data on its own, I think it's too early. I think we need more involvement from the tech community. Again, I come from the tech community, and I haven't seen enough work being done in that area. So that's it for me. Thank you.
Thank you. So I think one of the common threads throughout this is now we're at this post-high-tech era, this increasing necessity and challenge in accurately measuring the actual experience of the patients and what they do and how that reflects how our systems have been designed to support and advance them. I can go to questions. I've got a couple of questions. What do you think, Alex, is the scale of adoption for this type of patient engagement? I'm a techno geek through and through, but I'm not patient yet with entering any information into any phones. How fast do you think it's going to take to make this something that is more ubiquitous or accepted as part of this sort of deployment?
So I think that's where the opportunity lies. I think it's moving faster than we think it is. Most people have smartphones, and the relationship that we have with our smartphones is incredible. I mean, you know, my phone got discharged the day before yesterday, and I felt completely lost in the world. Like, and I think that's true for most of us. It's almost the most valuable device we have. I was at a meeting 2 weeks ago here in the Bay Area, and there were people that had been working in Syria with the refugees and in Turkey, and they were telling me that many of them had smartphones, and it was viewed as a necessity, not as something additional. So if you take that, you know, the technological advances, and the fact that we use them for so many things, it's just such a natural extension that I think this notion that consumers and people are not ready is not really accurate. I think we're the ones that are not ready, and we need to push this out. And what we found in our own deployments is that even those populations where we think it's the most challenging, they adopt it and they like using the technology because they see a benefit. You know, at the end of the day, you know, as long as we get a benefit from stuff, we will use whatever it is. So that's my view.
To hear Jeff's perspective on that. What's your perspective on the adoption? Because the focus of what I think a lot of what you've been describing is the loop needs to be closed.
Yeah, I think that the opportunities with wearables, with technology, with smartphones are ubiquitous, right? So, but you need to help the individual to understand what helps him or her in terms of behavior. This is where we're coming from, this is how we view the world. So how do we help people with devices or with apps or with a smartphone? The key point here is, to me, to help the person to view this as an asset rather than a toy, as a gimmick. What I always say is that starting an app is really easy. Nobody helps you to stop one. And there's really a cemetery of apps on many cell phones, and this is really frustrating for people with chronic diseases. So rather helping people into something is very important, but helping them to switch to something next is as important. So just throwing technology at you or apps at you, and the other day I was at Apple, they have more than 200,000 apps now in the health apps in the App Store. How do you help people to switch and choose what's relevant at the very moment is really key to us.
There's also growing out of data on most of our programs too, because of consequence of this. Do you have any perspective on that?
Well, I would just simply say that I think it's great that we're at a point in time where we can actually talk about person-centered care or patient-centered care and realize that that could not happen until we had the fundamental technology in place to allow that information to be accessed. So data transparency is critical. And for people to take control of their own healthcare, they need to know what's going on with their visits, the activities they're engaged in, the medications they're getting. And you had a good example of how you're using technology to help patients and people take better control of their own health. And we are now at a point in time where we can talk about this very credibly, whereas even just 5 years ago, that was really something that seemed more of a fantasy. So I think we have really moved very significantly. I think we'll move even faster. Person-centered care or patient-centered care is absolutely where a lot of this health system is going to be restructuring, but it has to take place with the technology that develops along with it so that it can make it easier for people to harness all the different pieces of the healthcare system around them.
Nick, we should probably turn it over, Q&A in the audience.
Is any questions from the audience for Abel? In the very far back.
Yeah, right here, sir.
Yeah, question for the AI Cure presenter. How much user analysis did you do on that? I'll give you a good case in point. My dad, 87-year-old, diabetes, multiple comorbidities, has a drug regimen between 15 and 20, 3 to 4 times a day. And most of those pills, when they hold them with their fingers, they're not even visible because they're so small. So how do you address applying that in that, what I would think is a pretty real-world scenario?
Yeah, so we do a lot of user studies. You know, what I said about design and the innovation process is real. We do user studies practically every week. We do studies with specific populations. Like last week we had a woman coming in who had never used a smartphone in her life. That's how we do the testing. So that maybe this is one part of it. We believe that it's really critical to get the experience right for the patient and for the user of the technology. In terms of the difficulties when you have many medications or they look in a certain way, it really depends on the therapeutic area and the goal. But we have mechanisms by which we can have the patient show the packaging, for example, to make sure that they're taking the right medication if they look too much like each other. So it's part of the platform. It's completely flexible because it's all based on machine learning. So we can train for different pills, and depending on what those pills look like, there can be additional steps to ensure the accuracy is higher. Does that answer your question?
In a way, but I really think realistically we could be adding many minutes, approximately an hour.
Yeah, so the comment was realistically you'll be adding many minutes. The reality is that it's very quick because all you do is hold it up and you take the medication. So it doesn't really add that much, and what we found with older patients is that they like it because when they don't take the medication, they get an SMS from their care providers or a phone call, and they they feel they're getting better care. So it's always a trade-off, right? If you're getting something extra, you're willing to spend the extra time, and there is a bit of an extra effort. But that's why I think the future is, when this becomes more of a health assistant where your dad or my dad, opens the app and the app says, hey, Alex, how are you doing? How are you feeling today? It's time to take your medication. You have a short dialogue. That by itself can be extremely powerful if it's done properly. And I think that's where things are going.
Get it, Matt.
I totally agree with that because as a family physician, I see non-compliance is a big issue. Every single note I have to write compliance emphasized, which has really no meaning because the patient is the same patient 10 years ago and still today is the same patient. But I think that's a brilliant thing you're doing because there are many ER visits where they are overdosed because they forgot that they took it. I recently had a patient who double-dosed herself on some of these Ambients. She thought she took it at 6 o'clock, she took it at 8 o'clock, she was on something else, Ativan, and blah, 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 and she was actually in the ER because a mom took her. And then she started putting the bottles upside down to remind herself that, oh, I took it. I mean, they go through different ways of their own creative, coming up with creative solutions, these patients. But the same thing with people who don't want to take the insulin because they just don't want to take it. So in the future or currently, is there something like an alarm? Because that's what we do in the office as doctors, set alarms for the patients. My med students, that's what they do, like literally programming their phones.
Yeah, so the way it works is, whether it's a clinical trial or a population health deployment, either the care providers or the patients themselves can set the alarms. So if the medication has a certain window and it has to be taken within that window, they get an alarm within that window, and if they don't take it, then somebody will contact them. So, and if the window is large, the patient can change the alarm. But yeah, they absolutely get the alarms. And that's part of the service, and I think the opportunity that mobile devices allow us, that it allows this connection with your health care provider, and that you can get additional information, which is exciting. If you take a medication, if you've had a stroke, and it suddenly tells you, you just reduce your risk of another stroke by 10%, that can be really valuable. You don't get that just from the pill. So that's part of what we're doing.
One more question, I think.
Thank you. In a number of sessions yesterday, the issue of interoperability, healthcare data interoperability came up, and specifically some of the challenges of lack of interoperability to new innovative kind of products that depend on access to clinical data collected and stored elsewhere. And I know some of you, for instance, Paul, I know has been very involved with interoperability, very knowledgeable about it, and has been involved in the development of interoperability standards. I guess my question to him and to all of you would be, now that you're on the other side, using those standards and seeking to access data, are you seeing facilitated interoperability? What types of interoperability have been facilitated? Or is interoperability still as difficult and challenging for third-party applications, if you will, as before?
Yeah, it's a great question. So it's definitely gotten markedly better. So for those of you that don't sort of fully know my background, so I've worked as a product development person in industry, and then spent some time developing standards and working with the Office of the National Coordinator, primarily around meaningful use stage 2 and direct, and certified EHR technology, and then went back into sort of the private sector from whence I came. And that was certainly some of what motivated it, right? Because sort of at the end of the last decade, moving this information in any kind of standardized way was just, almost impossible. My overall sort of lived experience around interoperability is, it's not that it's impossible to do, it's just that it today continues to still be sort of very expensive to do, right? And so when there's enough dollars associated with getting that information to move from point A to point B, because the use case is tangible enough, like the data will flow in that kind of context. The thing that's often difficult, especially around sort of novel use cases or when you sort of work at the sort of the periphery of things, it's hard to, for that particular problem you're trying to solve, make the business case close, right? Because the dollar per patient to do that across even that population just doesn't necessarily meet the needs of sort of the economics, right, of moving the data. But it definitely has, it has improved. I mean, there's things that like I'm now, able to do, right, sitting in Quantros that say 5 years ago I wouldn't be able to do. But having said that, I mean, the standard of still what I can sort of assume is probably out there is, meaningful use, right, and certified EHR technology related to it. So I happen to know those standards kind of intimately, so that gives me some sense of what the boundary of easy possibilities are for me. Certainly new technology that's coming, like FHIR down the road, will help, I think, move that along further. But it certainly is not, where I would like it to be, and it continues to be a challenge. So progress, yes, is being made. It's just more slowly than I would ideally hope, and I think that's probably true of sort of most folks that work in the interoperability space.
So I think we have one final question.
So thank you all for the patient-centered approach that all of you took in discussing analytics. I actually wanted to get some perspective on what you guys are doing for patients who want to pull their analytics, because they may not always be in the same platforms as they access and aggregate different data. And now, especially with more of the patient empowerment movement, as more and more patients are demanding that, what efforts are you guys pursuing to make it super easy to access and also digestible for patients to understand?
We work more with the payer and system folks as opposed to individual patients, but I know that perhaps some of you all have helped with having folks individually pick up their data and utilize it or look at it. We certainly are helping in the system the providers to better access and understand the data that they're incorporating and utilizing. And in so doing, we're making sure that we help push towards more data democratization so that people can better assess what is actually going on within the healthcare system for them.
Yeah, I mean, so from a patient safety perspective, obviously sort of pushing out sort of information about something that happened, I mean, that obviously happens in situations where something has gone on sort of very badly in a healthcare setting. What I'm actually more interested in getting in the context of patient safety especially is actually more information from the patient about their experiences. Because you often think about sort of patient experience, I think sort of neophytes look at it and they think like, it's kind of like a customer service score, about what's kind of going on and like, bedside manner wasn't so good or these kinds of things. But the reality is there is a very specific kind of correlation, right? So let's take that example of like sort of bedside manner wasn't so good. Maybe that means that discharge instructions weren't so clear, which means I'm not taking the medications, right, as I should have been, simply because it wasn't really well understood by me what was necessary in that kind of context. So is that any longer a patient experience kind of customer service problem? No, I would tell you that's a patient safety sort of issue, right? I mean, that's the kind of thing that will actually sort of move the needle or not, if you're not doing it well, on patient outcomes. So in at least the context of Quantros, I actually want to hear more from the patient rather than simply present data back to them, just because of the way in which we work.
think we need to add to this mechanistic view of the patient. Here's the data interoperability, and here's the medication reminder. And patients, as we heard this morning, which I really enjoyed, let's talk about persons and talk about, so how do we enable people? We will be overwhelmed by the tide of chronic diseases if we rely on this. Very important, interoperability, all of this is a prerequisite, but you need to add to the patient's ability to manage him or herself quite a lot. You can make access through platforms like ours and others, the data to operate on, or the data availability or safety, or what you call. Medication reminders is one thing, but people don't want to be diseased, period. So, and they want to forget about it. And as long as you don't add the other side in terms of adding to life quality so that they manage the disease to get the happiness back, we are focusing too much on the disease. We need to focus on the access to being content, being in peace with yourself. And this is what we physicians can actually help the patients to do. And then all this data stuff is very important, but it's only a part of managing individuals.
Just one quick question going to Sam.
I just wanted to follow up on the interoperability question. It is very important that interoperability occur. The only way we're going to get to all this nirvana state that we all like to get to is when the data will be freely transportable, movable, and understandable across multiple systems. There are examples where that's going on. Certainly you're aware of them. The Institute of Medicine is working on some issues right now around establishing consensus around genomic test alerts in partnership with electronic health record vendors. So there is work going on in multiple spaces. Again, I would just simply ask people to think about this as this is an iterative improvement in health as we move along. 10 years ago, everything was paper. We have moved to electronics. We're now at the point where we've got data collected and stored in EHRs, and the next stage is now the analytics to help harness that data, and the stage after that is ensure that everybody's in charge of their own healthcare. We are going to get there. It's going to happen, and there are a number of players in the system that are going to make that happen. All of you sitting in the audience as well. We will get there, and it's a continuous forward progression.
That's a great place to end, and I really want to thank terrific panel. I learned a lot. I think that probably all of you did as well. So thank you. Let's give them a hand. I want to announce